Hi there, my name is Catalina Arenas, and I hope you enjoy my presentation on the anatomy of a local anesthesia. So, on the screen right over here, we have some learning objectives. So, today we're going to learn about the structures that are anesthetized. We're going to locate and identify anatomic structures on the skull and the client, demonstrate the correct placement for the needle, identify different types of tissues involved during the insertion of the needle, effective injection versus ineffective injection, and all you need to know about needles. So I really like this image over here displayed from our textbook. This essentially shows the entire oral cavity, both the maxillary and the mandibular arch, and talking about the different areas that can be anesthetized, what teeth structures, if it's, the buccal or the lingual surfaces that are anesthetized, if it's also pulpal anesthesia or nerve anesthesia involvement. We'll go further into each and every single one of them throughout the duration of this lesson. Okay, so we're just going to start off with maxillary nerve anesthesia. So we are starting off with the PSA block, otherwise known as a posterior superior alveolar block. It's a maxillary nerve anesthesia. It anesthetizes the maxillary molars and associated buccal periodontium, including the gingiva within one maxillary quadrant. Um, this injection is not really used as much because it can be replaced with other injections such as the greater palatine, but it is good for people who just feel pain in either one of these areas of the teeth. Um, Really good for debridement as well, especially if these areas are sensitive, painful, and whatnot. So the injection site is at the height of the mucobuccal fold, superior to the apex of the maxillary second molar, distal of the zygomatic process. This is going pretty far back um, into the client's mouth, so it's typically very uncomfortable for them. This injection is also distally superior than the maxillary tuberosity. So this is where we would want the injection site to be at. And obviously what the textbook kind of stressed out is the correct needle and syringe barrel angulation to the injection site must be maintained throughout using three different orientations, but only one movement. This angulation should be superiorly at a 45-degree angle to the maxillary occlusal plane, medially at a 45-degree angle to the maxillary occlusal plane, and posteriorly at a 45-degree angle to the long axis of the maxillary second molar. To help accomplish this, the syringe barrel should be extended from the ipsilateral labial commissure. This complex orientation can be practiced using a topical anesthetic laced cotton tip applicator to palpate the injection site as if it were the needle in the syringe, as can all injections. We'll also get into a little bit more of needle shapes and length of needles near the end of the presentation. So successful injection, the patient will probably get some anxiety as soon as the injection is done because they don't get the instant anesthetic feeling. So they're probably just going to have a little bit more anxiety from that, but that essentially signifies a successful injection. And if the tooth that is affected is tapped on and they feel like this dull pain, that means it's also a successful injection. So possible complications is that this insertion of the needle is at a high risk of positive aspiration due to blood vessels in the posterior, inadvertent and harmless anesthesia of other nerve branches, and could end in extraoral hematoma if inserted way too far. And moving along, we're onto the MSA block or the middle superior alveolar block. It is, in fact, a maxillary nerve anesthesia. It anesthetizes the maxillary premolars and the mesiobuccal root of the maxillary first molar and associated buccal periodontium and gingiva. The injection site is at the height of the mucobuccal fold, superior to the apex of the maxillary second premolar. So this injection is only present in about 28% of cases. 72% of cases are people missing this nerve, so this cannot be anesthetized. So it is useful to use other areas of the oral cavity to anesthetize this area, such as either only greater palatine injection can be done for this area as well. Successful injection indicates that the patient will feel a harmless numbness of the upper lip, and possible complications are low risk of positive aspirations and hematomas, but they're extremely rare. And so now we're moving on to the ASA block, or the anterior superior alveolar block, which anesthetizes the anterior superior alveolar nerve and thus anesthetizes the maxillary anterior teeth and associated labial periodontium and gingiva to the midline within one maxillary quadrant. It's commonly used in conjunction with the MSA block instead of just using the IO block alone to anesthetize these teeth. The injection site is at the height of the nuchobuccal fold superior to the apex of the maxillary canine. Some successful injection indications, the patient will feel harmless numbness of the upper lip, and some possible complications are low risks of positive aspiration and hematomas being rare. And now we're moving forward with the infraorbital block, or the IO block. It anesthetizes the infraorbital nerve and also both the anterior superior alveolar and middle superior alveolar nerves, as to cover both of the regions of the MSA and the ASA blocks within one injection. So the IO block anesthetizes the maxillary anterior teeth and premolars, as well as the associated facial periodontium and gingiva to the midline within one maxillary quadrant. This is probably one of the most scariest injections to get because it is going so close to the eye. The injection site is at the height of the maxillary mucobuccal fold superior to the apex of the maxillary first premolar, and the length of the needle actually needs to be determined by measuring it with the index finger and the thumb. So as you can see at the bottom picture on the slide, you can see the clinician measuring and feeling where this little indent is at the infraorbital rim of the eye, and measuring to see how far or how long the needle needs to be in order to reach this area of the face in order to complete or have a successful injection. So some indications of successful injections, the patient will feel numbness in the ipsilateral upper lip, medial part of the cheek, side of the nose, and the lower eyelid. Some possible complications is that, hematomas rarely occur, but it'll most likely show up right underneath the eyelid. Sorry, didn't mean to say eyelid, I meant to say eye rim. So now we're moving forward on the GP block, or the greater palatine block. This anesthetizes the greater palatine nerve and thus anesthetizes the posterior hard palate and the associated palatal periodontium and gingiva of the ipsilateral maxillary posterior teeth within a maxillary posterior sexton. Because GP block doesn't provide anesthesia of the pulp or associated facial periodontal and gingiva area of the teeth, the administration of ASA, MSA, and PSA blocks, or the IO block, may also be indicated. In addition, anesthesia of the associated palatal periodontium and gingiva of the maxillary first premolar may prove inadequate because of the overlapping of nerve fibers from the anteriorly placed nasopalatine nerve. So this lack of anesthesia may be corrected by additional administration of anesthesia in the nasopalatine block if the patient is still feeling discomfort during treatment. So the target area for injection is located at the junction of the alveolar process of the maxilla and the posterior hard palate, as well as the superior to the apex of the maxillary second or third molar. Some indications of successful injection is the absence of discomfort, and the client could possibly gag if the soft palate was also anesthetized, but it's completely normal, and there are no possible complications reported with this injection. The NP block, or the nasopalatine block, is the next one that we're going to explore. It anesthetizes the anterior hard palate and the associated palatal periodontium and gingiva for the maxillary anterior teeth bilaterally from maxillary canine to canine within the maxillary anterior sexton. So this is sexton 2. Thus, both the right and the left nasopalatine nerves are anesthetized by this one block. Unfortunately, this does not anesthetize the pulp or associated facial, periodontal, and gingival areas of the teeth, so it has to be used in conjunction with MSA, ASA, or IO block. The injection site is located at the midline between the articulating palatine processes of the maxillae. This has to be 10 millimeters measured posteriorly from the maxillary central incisors. Some indications of successful injection is the numbness of the anterior hard palate and the absence of discomfort during procedures, and there are no possible complications. But hematomas can occur, they're extremely rare. So last but not least, we're touching on the AMSA block, otherwise known as the anterior middle superior alveolar block. So this injection anesthetizes a large area innervated by the anterior and middle superior alveolar nerves, as well as the nasopalatine and greater palatine nerves in the maxillary arch. Thus, the single-site palatal injection of the AMSA block can anesthetize the maxillary anterior teeth and premolars, as well as associated facial periodontium and gingiva of anesthetized teeth to the midline, hard palate, and associated palatal periodontium and gingiva of the ipsilateral maxillary posterior teeth and maxillary anterior teeth bilaterally. This anesthesia is without the usual collateral anesthesia of the upper lip and muscles of facial expression. Thus, the ipsilateral maxillary molars may have anesthesia of the associated palatal periodontium and gingiva, but do not have pulpal anesthesia or anesthesia of the associated buccal periodontium and gingiva. Additional administration of the PSA block will add this necessary anesthesia coverage to complete the maxillary quadrant anesthesia. So, fun fact, this is probably the most used in dentistry for cosmetic procedures. The injection site is located on the hard palate superior to the apices of the maxillary premolars and approximately midway between the palatal gingival margin and the median palatal raphe overlying the median palatal suture. Some successful indications of injection is the absence of discomfort, and possible complications are the blanching of tissue ischema, and sloughing if too much or excessive amounts of the local is administered. Otherwise, other complications are extremely rare. And now we're moving on to mandibular nerve anesthesia. So starting off on the mandibular nerve anesthesia, we are starting with the inferior alveolar block, otherwise known as the IA block. It's the most commonly used injection in dentistry. The IA block anesthetizes the mandibular teeth to the midline and associated lingual periodontium and gingiva to the midline, as well as the associated facial periodontium and gingiva of the mandibular anterior teeth and premolars to the midline within one mandibular quadrant. Thus, the IA block anesthetizes the inferior alveolar nerve and its nerve branches, as well as the lingual nerve. However, not all of the nerve branches of the mandibular nerve are anesthetized with an IA block. It's not considered a true mandibular block. Actually, the Go-Gates mandibular block is considered a true mandibular block since the entire mandibular nerve is anesthetized within one mandibular quadrant. This can be used in conjunction with a buccal block, and the injection spot is at the depth of the pterygoid mandibular space on the medial border of the mandibular ramus. The IA block had to have a separate slide for the indications of successful or unsuccessful injections or possible complications. So, for successful injection indications, normal numbing and tingling sensation of the lower lip to the midline is completely normal. Harmless numbness and tingling of the body and the tongue. A lot of people do get this reaction as well. Some possible complications with this injection is lingual shock, which is completely normal. That's just the loss of sensation of the tongue. It'll go away in a few hours. Same for transient facial paralysis. This will also go away in a few hours. People are at a higher risk of positive aspirations, hematomas, self-inflicted trauma, and paresthesia with this local anesthetic. And now we're moving forward with the buccal block. The buccal block anesthetizes the long buccal nerve and thus the associated buccal periodontium and gingiva of the mandibular molars within one mandibular quadrant. Many times, this block is not necessary if the buccal tissue is not impacted by the dental procedures provided. However, the buccal block together with an IA block will complete the mandibular quadrant anesthesia. The target area for injection is the mandibular ramus in the area of the retromolar pad overlying the retromolar triangle. And the injection should be distal and buccal to the most distal mandibular molar. In successful injections, there's no overt indications of an effective injection because of the location and the small size of the anesthetized region. There's usually only an absence of discomfort with dental procedures, and in some cases, self inflicted trauma for possible complications can occur, such as cheek biting. Otherwise, this injection has low risk of positive aspiration, and the complication of hematomas rare. And our final injection site for the mandibular arch is the incisive block. So the incisive block anesthetizes the mental and incisive nerves and thus the mandibular anterior teeth and premolars as well as associated facial periodontium and gingiva to the midline within one mandibular quadrant. However, if anesthesia of the associated lingual periodontium and gingiva of these teeth is necessary, the additional use of the IA block would be administered. The injection site is at the mandibular ramus in the area of the retromolar pad overlying the retromolar triangle, and it should be used distal and buccal to the most distal mandibular molar. And so we're moving forward with needle anatomy. So there's actually different needle measurements and requirements needed for each and every single shot. There are three lengths that are available for dental needles, which is long, short, and ultra short. The two most common needle lengths are the traditional long and the short, and they can all vary by the manufacturer. But typically, the long needle is about 32 millimeters, and the short is about 20 millimeters. The long needle is required for mandibular blocks because the depth of the penetration ranges from 20 to 25 millimeters for an average adult, um, 20 to 25 millimeters for the inferior alveolar, and 25 millimeters for the Go-Gates injection. So in my slide over here, I just have the different kind of needle anatomies. So you can see in the first picture, figure one, you have the dental anesthetic needle components. The end or the tip of the needle is the bevel. And then you have the shaft, and the little cap portion of the needle is called the hub. There's the syringe adapter and the cartridge penetration end. And then you could see in the second photo all the different sorts of sizes. Okay, and now we're just going to move forward in speaking about the needle bevel. So, experts have discussed that the angle of the bevel, as it relates to the long axis of the needle, may affect the degree of the needle deflection. Although not critical to the success of injections, bevel design remains a topic of discussion and study. The orientation of the bevel should be towards the bone during injections that are close to the periosteum. Doing so increases patient comfort and reduces trauma to the person if the bone is still contacted. Some clinicians consider adjusting the bevel to facilitate placement of the anesthesia closer to the nerves. Others suggest that during deeper penetrations, deflection can cause deposition away from the target if bevel orientation is not adhered to. So I found this awesome chart provided by RDH Mag, and it essentially shows you exactly which needle you need for all of these injections in order for them to be successful. Thank you for listening. I hope you enjoyed my presentation and you learned a little bit more about local anesthetics. Get ready for your board exams.